Good afternoon, Commissioners. We are now live.
Good afternoon. Good afternoon to my fellow commissioners and to all who have signed in on the live stream. We are going to have our first action be to vote to enter into confidential executive session. So for those of you on the live stream, we expect the board to return to our public meeting at approximately 1 p.m. And our order of business before we vote to move into executive session will be to vote on the minutes from our last board meeting, which was October 10th, 2024. And I'll turn it over to Colleen Elstermeyer for that vote.
Thank you so much, Madam Chair. We did have one amendment to the original minutes from Commissioner McGregor, so you are voting on an amended set of minutes. Could I ask for a motion?
So moved.
And a second.
Second.
Okay, and I'll ask each commissioner present to vote, starting with Chair DeVoe.
Aye.
Vice Chair Cohen.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Aye.
Commissioner Foley, I think, is not attending today. Commissioner Haupt.
Aye.
Commissioner Mastrogiovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Sullivan from A&F.
Abstain. I wasn't here.
Thank you very much. And Under Secretary Mahania from EHS.
Aye.
Thank you very much. Okay, back to you, Madam Chair.
Okay, great. So we now need to take a vote to enter into the confidential executive session. And for those of you who are on the live stream, we expect to return to the public session at approximately 1 o'clock. And let me turn it over to you again, Colleen, to handle the vote.
Okay, great. So I'm now asking for a motion to enter into a confidential executive session. Can I ask?
So moved.
Great, thank you. And a second.
Second.
Okay, Chair DeVoe, how do you vote?
Aye.
Vice Chair Cohen.
Aye.
Commissioner Blakeney. Barbara, yes, thank you.
Sorry, aye.
No worries. Commissioner Cutler. Yes. Commissioner Haupt.
Aye.
Commissioner Mastrogiovanni. Yes. Commissioner McGregor.
Aye.
Commissioner Sullivan.
Aye.
And Secretary Walsh, welcome.
Aye. Aye.
Okay.
Commissioner Castile is here too.
Oh, Commissioner, hello. How do you
Hi.
vote?
Good, thank you.
Thank you. Welcome. Okay, and with that, we will adjourn to executive.
Okay, welcome to the HPC's final public meeting of 2024. I'm Deb DeVoe, and let me take a minute to just review our agenda for the meeting this afternoon. Our first agenda item is going to be a presentation from the Office of the Attorney General on the findings from their 2024 examination of healthcare cost trends. Our second agenda item will be for the Health Policy Commission staff to share our evaluation findings from Mass General Brigham's Performance Improvement Plan, PIP, before commissioners vote to determine.
Madam Chair, I'm so sorry. We're actually not live. We need to wait for the verbal cue from Andrew.
Oh, I thought he said
So-
the pop-up was the cue. Sorry.
No, apologies for any confusion, but we are
mistake.
now live.
Thank you, and welcome back to the HPC's final public meeting of 2024. I'm Deb DeVoe, and let me just start by reviewing our agenda. Our first agenda item is a presentation from the Office of the Attorney General on the findings from their 2024 examination of healthcare cost trends. Our second agenda item is that the HPC staff is going to share evaluation findings from Mass General Brigham's Performance Improvement Plan, PIP, before commissioners vote to determine if Mass General Brigham's PIP was successful. Our third agenda item will be for our research team to highlight new data on behavioral health emergency department boarding in Massachusetts. And then we'll close with agency updates in our executive director's report, as we always do. Before we turn to our first presenters, I'd also like to acknowledge and welcome Dana Sullivan, the new designee to the commission on behalf of the Executive Office of Administration and Finance. Welcome, Dana. Now we will turn to our guest presenters. We're grateful to have Assistant Attorney Generals Lisa Garland and Chloe Cable with us today to share findings from the 2024 AGO Cost Trends Report. Each year, the Office of the Attorney General conducts examinations, the findings of which are included in their Cost Trends Report and issued in conjunction with the HPC's annual Healthcare Cost Trends hearing. Their report this year focused on healthcare affordability, which has been an area of significant focus and concern for the HPC, and which was highlighted during the Attorney General's remarks at this year's Cost Trends hearing. I'll now turn it over to the AGO team to begin their presentation. Thank you.
Thank you. Hi, and good afternoon. So I am Lisa Garland, an Assistant Attorney General in the Healthcare Division of the Office of Attorney General and one of the authors of our 2024 Cost Trends Report. You'll also be hearing from my colleague, Assistant Attorney General Chloe Cable, another report office author during the presentation. And we thank you for the opportunity to present on our 2024 Cost Trends examination, findings, and recommendations. Next slide, please. So I'll start out with a little context concerning our role. As previously mentioned, the Attorney General has been tasked with monitoring trends in the healthcare market, including trends around patient access. Our office has statutory authority to issue subpoenas for documents, interrogatory responses, and testimony under oath related to healthcare costs and cost trends. And then we use the data and information collected to examine topics impacting healthcare access and costs, culminating in a report. As was mentioned, our reports have been issued in conjunction with the HPC annual cost trends hearing since 2010. And again, this year, our examination concerns healthcare affordability with a specific focus on affordability for Massachusetts residents with commercial health plans. And part of our motivation to focus on that was recognized in the Attorney General's strategic plan that health is fundamental to a person's ability to participate fully in every aspect of their life. So accordingly, one of the office's strategic priorities is effectuating access to healthcare, which means in part working to ensure that every Commonwealth resident can access care that meets their medical needs, but importantly is also affordable. And we know that for a substantial number of residents across the Commonwealth, that's not currently the case. It is an issue that our office sees every day, including through work done by our mediation unit, which regularly hears from commercial health plan members facing large medical bills that they simply cannot afford, whether it's for an out-of-network ambulance ride, as detailed in a report last year, or it's an unexpected facility or an expensive lab charge subject to a deductible, as just some examples of what we state. Next slide, please. So our 2024 examination looks at healthcare affordability through several lenses. So first, we assess the capacity of Massachusetts households to pay for their healthcare by examining how much households with commercial insurance are spending on healthcare expenses relative to their income. So as we observed in the report, affordability is contextual. It's not just about absolute prices and costs, which are certainly a significant component, but it's also about the ability of a household to absorb costs based on their resources, whether that be insurance coverage or household income. And so to do this, we issued civil investigative demands, CIDs, which are basically subpoenas, to 11 commercial health plans in Massachusetts, pursuant to which we were provided significant data, including member cost share responsibility and benefit design, including deductible level by zip code. And we also received some reporting on premium contributions that plans had provided to CMS pursuant to fairly new requirements. So that's the insurance side. And we also looked at certain hospital side metrics relevant to affordability. Next slide. First, we examined to what extent are commercial health plan members incurring medical debt from hospital bills. And then second, we assessed to what extent are Massachusetts safety net and lower cost hospitals burdened by bad debt. And so to answer these last two questions, we sent CIDs to 12 hospitals across Massachusetts, seeking, among other information, financial assistance policies and data relating to commercial patient debt arising from services rendered in 2022. And you'll be hearing from Chloe on these questions later in the presentation. Next slide. So as previously noted, one of the ways we assessed affordability was to look at household spend on healthcare relative to income. So as part of this inquiry, we began by assessing health plan benefit design with the objective of understanding deductible exposure by income quintile, and also to examine specifically whether residents in lower income communities are disproportionately enrolling in higher deductible health plans. So as cited in our report, research shows that higher deductibles are correlated with a higher likelihood of having medical debt, and they may also serve as a significant barrier to obtaining healthcare in the first place, particularly for lower income households. Next slide, please. And so our finding to that inquiry was actually no. Households in lower income zip codes in general are not disproportionately enrolled in higher deductible health plans relative to those in higher income zip codes. So rather, as reflected in this graph, 2022 data shows that there was relatively even distribution of Massachusetts residents' enrollment in deductible level groupings across income quintiles. So the graph on this slide reflects commercial enrollment in 2022. And I do note, though, that it excludes data relating to plans for members receiving cost share reduction or CSR subsidies. So at the right, you can see the 6 deductible level buckets that we looked at. Dark blue bars at the bottom denote enrollment in plans with the no deductibles. And then moving upward, there's increasing deductible levels through light green, which represents deductible levels of $5,000 or more. Across the bottom, we have income quintiles displayed, and these are calculated based on 2021 IRS filings. They were the most recent IRS data available at the time. The lowest income quintile is on the left, the highest is on the right. And so as shown, the percentage of enrollment in plans with no deductibles, again in the dark blue bar, was almost the exact same across income quintiles in 2022. But then excluding no deductible plans represented in dark blue across all income quintiles, we see highest percentage of enrollment in the middle level bucket represented in light gray here. And so these are deductibles ranging from $1,000 to $2,499. And so this result was somewhat surprising to us, but from a consumer affordability perspective, it offered a little reassurance that lower income households are not overrepresented in higher deductible plans that can result in financial struggles. But of course, as we observed in the report, there are still some number of lower income households with deductibles, even at lower levels, that will still face financial exposure that they cannot afford. Next slide. So with an understanding of the distribution of potential exposure through deductibles, we next looked at actual cost share responsibility and spending on premium cost contribution from Massachusetts households with commercial health plans in 2022 to assess how healthcare spending varies as a percentage of household income across income quintile. Next slide. So to do so, we first focused on cost sharing alone and calculated the average out-of-pocket cost sharing spend for Massachusetts households in 2022 across quintiles. So our findings are reflected in this chart, again, arranged from lowest income quintile on the left to highest on the right. So before discussing findings, just another note on methodology. So to estimate household spending here and throughout the report, we first calculated per member per year spending based on the data provided by the plans. And then we converted that to a household estimate by multiplying by 2.46, the average number of household members in Massachusetts based on census data. And so based on this modeling, we found that out-of-pocket cost share responsibility in 2022 was lowest for households in the lowest income quintile, so on average, nearly $1,650. And by contrast, households in the highest income quintile had the highest out-of-pocket spend, on average $2,105. So in 2022, Massachusetts households in highest income zip codes on average incurred approximately $450 more in cost share responsibility than Massachusetts households in lowest income zip codes. So next, we examined spend on cost share relative to average income across the income quintile. Next slide. So the graph in this slide shows the results of that analysis. In 2022, households in lowest income zip codes, represented by the bar farthest to the left, on average spent 2.9% of household income on cost sharing, approximately 4.5 times more than households in the highest income zip codes, shown at the far right, which spent on average 0.6% of income on cost sharing. So we think it's important to note, as we do in the report, that while this data is presented as an amount spent on a yearly basis, that's not necessarily how healthcare spending works. So out-of-pocket spending and cost sharing is not evenly distributed or divided across 12 months, like a loan payment or rent may be, or payroll periods, as is a premium contribution. So certainly in some instances, it's important to recognize that this could mean the bulk of out-of-pocket expense comes in a single month or a couple months. For example, it could be, again, an expensive ambulance ride or imaging subject to a deductible, making it even more difficult for lower income households to allocate limited budgets for healthcare spending, particularly if it's an unexpected expense. So even though, as we will see, household spending on premium contribution is higher than is cost sharing, the data shows, and we should recognize, that out-of-pocket cost share itself can be a significant component of affordability for some households. Next slide. So in addition to looking at the Massachusetts market as a whole to further assess potential affordability gaps, we also broke out spending relative to income by market segment. So we separately looked at data for households who were enrolled in the individual market and those who had employer-sponsored plans in 2022, as shown here. The households enrolled in health insurance through an employer, which is the vast majority of Massachusetts residents with commercial insurance, are represented by the orange bars. And the households getting health insurance through the individual market are represented by the blue bars. So we note that this data does include enrollees with CSR subsidies. And we found that households in the lowest income zip codes with employer-sponsored plans paid, on average, nearly $550 more in cost sharing than the same households in the same lowest income zip codes enrolled in the individual market. So a very meaningful difference at this income level. And so relative to income, that means that, as shown in the graph here, in 2022, households with employer-sponsored insurance spent, on average, 1 percentage point more of their income on cost sharing compared to households in the same lowest income zip codes, but enrolled in the individual markets. So the results, we think, generally reflect the reality that in the individual market, there is recognition that households with lower incomes have less capacity to spend in healthcare, and so income-based subsidies may be necessary to reduce out-of-pocket responsibility and enhance affordability. Whereas the employer market does not have this built-in recognition, and lower income households with employer insurance are not similarly eligible for subsidies. So as we point out in this report, and as surveys have reflected, lower income families with employer-based insurance may be particularly vulnerable to affordability challenges. Next slide. So the previous slides reflected analyses around cost share spend only, but we also wanted to assess affordability implications when household premium contributions are folded into the mix. So to calculate household premium contributions, we used reporting made by 8 health plans to CMS concerning member contributions in conjunction with premium data reported by these same health plans for their fully insured membership. And in these calculations, to be clear, we are not including the employer contribution. So as you know, with respect to premiums for employer-based insurance, a portion is paid by the employee, but typically a larger portion is paid by the employer. And so the employer contribution is considered to be part of the employer's compensation and of course impacts take-home wages, which is to say that if the employer paid less in premium, the employees may see higher take-home pay. So certainly total premium does affect employees' ability to afford healthcare. But we chose to focus on the average premium contributions made by households rather than total premium to get a better sense of actual household expenditures relative to income and understand, to a better effect, the more direct implications on a household budget. And so based on our modeling, we estimate that on average, premium contributions for households with fully insured plans in 2022 range from approximately $5,600 in the lowest income quintile to nearly $6,800 in the highest income quintile. And so when we combine household premium contributions and cost sharing and calculate relative to income across income quintiles, there's significant variation in what households in the lowest income zip codes on average are spending relative to those in the highest income zip codes. So specifically, we estimate that in 2022, fully insured households in the lowest income quintile on the left spent on average 13% of their income on cost sharing plus premium contribution. So nearly 5 times more than fully insured households in the highest income zip codes, which we estimate to have spent 2.7% on average. Next slide. So in addition to analyzing spending across income quintiles, we also analyze how affordability burdens for commercial plan members may vary across the state. Next slide. And so to do so, we use the 7 rating regions used by health plans for merged market rating and added a geographic description for a little context. And so the graph here shows the average spending on premium contributions and cost sharing for fully insured households relative to average income across these 7 regions. And the green line shows the average income. As shown, we found that there is significant variation across regions in terms of percentages of income spent. So on average, fully insured households in Cape Cod and the islands spent a much higher percent of income, 9.6%, than fully insured households in Eastern Massachusetts, for instance, which was at 3.9%. And we will also highlight, for purposes of the next slide, that households in the Northeastern region were falling somewhere in the middle, spending on average 6.5%. So there may be different reasons for this variation. Some of this is difference due to variation in average income. The data is also not health adjusted, so it may be indicative of differences in morbidity and age. But importantly, as we observe in our report, one significant limitation of this analysis is it is built on averages that can obscure nuance. So we thought it would be informative to get behind these averages a bit. Next slide. And so here we have disaggregated the data by taking some of the sample zip codes and rating area for the Northeastern region in the last slide, including some higher income zip codes as well as lower income zip codes. And while fully insured households in rating area 4 as a whole has spent on average 6.5% of household income on premium contribution and cost sharing, when you pull out some of these zip codes, you can see that households in the lower income zip codes spend a significantly higher percentage of household income. So this includes for some of the Lowell North zip codes at the right, nearly 16%. And so what we're seeing here is that when you look at averages, particularly over large population segments, you may be significantly understating affordability burdens for some of that population. I will also add that not shown here, but in our report, if you're interested, we also layer on some additional expenses looking at, for these same zip codes, average household spending on food and housing. Our analysis shows that households in these same lower income zip codes that are spending relatively high percentages of their income on healthcare are also spending a disproportionate amount of income on housing. So for example, in addition to spending 16% of income on healthcare, zip codes in Lowell and Lawrence on average, we're also spending over 30% of income on housing in 2022. So we suspect a meaningful number of households in these zip codes may likely be struggling with healthcare costs, spending a significant portion of their budget on housing, which could potentially mean that they're limiting needed healthcare or incurring medical debt, which, as I noted, was also indicative of affordability burdens. And so I will turn it over to AAG Chloe Gable. Next slide, please.
Thank you, Lisa. The next section of our presentation focuses on the impact of hospital medical debt on the commercial health plan members. For this portion of our report, we used data from 11 hospitals for patients who received services primarily in 2022 who had bills overdue past 120 days as of April 2024. And the reason I say primarily 2022 is because one hospital in our sample had to give us information from April 2022 to March 2023. And we use this information to examine which populations are most likely to incur medical debt. Next slide. We requested zip code information at the patient level from the sampled hospitals, and we used the same income quintiles we previously showed in other slides to determine how debt from our sample was distributed based on income. What we found was that in 2022, patients in lower income zip codes accounted for more debt than patients in higher income zip codes in our sample. And as you can see here, we have the income quintiles at the bottom with the lowest incomes on the left and the highest on the right. And the lowest income quintile accounted for 31% of debt in our sample, compared to the highest income quintile, which only accounted for 6% of the debt. And notably, over half, or 53% of the debt was held by patients in the two lowest income quintiles. Patients in the lower income quintiles also had more debt on average, with patients in the lowest income quintile having $554 in debt on average, and then the second lowest had $640 in debt on average, compared to the highest income quintile, which had $502 in debt on average. Next slide. We also looked at patient gender and found that in 2022, from our sampled hospitals, female patients had more debt, while male patients had higher amounts of debt on average. So as you can see, 56% of patients with debt were female and 44% of patients with debt were male. However, the male patients had $618 in debt on average, while female patients had $493 in debt on average. And a potential reason for this could be that we see higher utilization of medical services by women, and that might explain why there's a higher proportion of the patients in our sample who are female. Next slide. We also looked at racial data for patients in our sample and found that Black patients made up a higher percentage of patients with medical debt compared to their share of the statewide population. 12% of patients with debt from our sampled hospitals in 2022 were Black, while only 7% of Massachusetts residents are Black, according to the 2020 census. In contrast, other racial groups, including white and Asian, made up a smaller proportion of patients with hospital debt compared to their share of the statewide population. 63% of patients with debt were white, while 68% of the statewide population is white, and 3% of patients with debt were Asian, while 7% of the statewide population is Asian. And unfortunately, due to data limitations, we are not able to make any conclusions about other racial groups. Next slide. We also wanted to know what types of services led to hospital medical debt, and found that in 2022, outpatient services generated more debt, while inpatient services generated higher amounts of debt on average at our sampled hospitals. Outpatient services accounted for 80% of hospital debt, while inpatient services accounted for 20% of debt. However, patients with debt from inpatient services had about $2,315 in debt on average, compared to $458 in debt on average held by patients who received outpatient services. And this is likely because inpatient bills tend to be higher. So this might result in higher amounts in deductibles, co-payments, and cost sharing that the patients might not be able to afford, leading to this higher amount of debt. Next slide. So after examining the patient populations most likely to incur hospital medical debt, we looked at hospital financial assistance policies to determine how these policies support patients who cannot afford their bills. Next slide. We reviewed 12 hospital financial assistance policies, and what we saw was that qualification for these policies varied greatly hospital to hospital. Most hospitals consider discounts for patients based on the patient's income relative to the federal poverty level. But income threshold caps that hospitals used ranged from 200% of the FPL to 600% of the FPL and everywhere in between, as you can see on the left. And very few hospitals offer discounts to patients above 300% of the FPL. Most hospitals also required the patients be screened for eligibility for financial support from the health safety net prior to being considered for a discount from the hospital itself. And only 2 of the sampled hospitals indicated they might offer discounts to patients on top of assistance they receive from the health safety net. Next slide. We also saw that very few hospitals provide discounts to cover bills for deductibles or coinsurance. Of the 12 hospitals sampled, 9 indicated they would not provide discounts to cover costs for deductibles or coinsurance. The other 3 had unclear policies, and the versions of the policies we were provided varied from versions that were published on their websites, which made it difficult to reach conclusions about whether discounts for the deductibles and coinsurance might be offered to patients at those hospitals. There's also so a lot of variation and confusion in these policies. What we know is that commercial patients who struggle to pay their patient responsibilities are likely dealing with bills for deductibles and coinsurance and are likely unable to receive discounts from the sampled hospitals for those types of bills. Next slide. For the next section of our presentation, we consider the impact of unaffordable patient bills on hospitals, particularly on safety net and lower cost hospitals. We use data from 11 hospitals for patient bills from services rendered in 2022 that were still unpaid as of April 2024 as a proxy for 2022 commercial bad debt. Bad debt being bills that are not collected and are ultimately written off as a loss. We use this information to determine how a hospital's public payer mix and commercial relative price correlates with its level of bad debt. Next slide. We compared the sampled hospital's bad debt relative to their commercial gross patient services revenue, or GPSR, to their Medicaid and subsidized population payer mix. And on the chart, you can see the percentage of commercial bad debt to commercial GPSR on the bottom. And then on the left is the Medicaid and subsidized population payer mix, which also includes, for example, connector care and health safety net funding streams. What we saw was that the hospitals with a higher Medicaid and subsidized population payer mix also had a higher percentage of commercial bad debt relative to their commercial GPSR. Next slide. We then compared the sampled hospital's bad debt relative to commercial GPSR to each hospital's statewide commercial relative price, and found that the hospitals with a lower commercial relative price had a higher percentage of commercial bad debt relative to their commercial GPSR. What this tells us is that lower cost hospitals that serve lower income populations, and these being hospitals that may already be operating at a deficit and may be at a higher risk of closing services, are disproportionately impacted by bad debt. Now, based on these findings, we will turn to our recommendations, and I will pass it back to Lisa. Next slide.
So thank you, Chloe. So as Chloe mentioned, our report concludes with 8 recommendations that flow from the findings and that we could believe would help advance efforts towards affordability. But we first note, however, that while our examination this year did not include an analysis of healthcare prices or an examination of provider price variation, these are, of course, important factors in the affordability equation. So at the outset, we recognize here, as we emphasized in our report, that any holistic efforts to address affordability must include containment of excessive provider prices, as the HPC itself has recommended, while also addressing provider price variation in a way that will preserve lower price, high quality healthcare options. At the end of the day, we think it's important to recognize that consumer protection includes investing in and sustaining affordable healthcare options for all Massachusetts residents. So with that context, we make the following recommendations. So first, we recommend that the legislature consider creating an affordability index that measures how much Massachusetts consumers are paying for healthcare, as well as a target affordability benchmark. Importantly, we recommend that affordability index should allow policymakers to monitor affordability trends at a municipal or zip code level. As reflected in a report, this would allow a more nuanced understanding of affordability burdens and could allow for potential identification of geographic pain points that may not be identified through statewide or regional averages. Next slide.
We also have a number of recommendations to improve protections for consumers who are facing unaffordable medical bills. First, around the collection and reporting of medical debt, we recommend limitations on collections and extraordinary collection actions during good faith bill disputes. We also recommend limitations on reporting medical debt to credit bureaus. Regarding financial assistance policies and practices, we recommend uniform income thresholds for eligibility, screening requirements, discounts that apply to cost sharing, affordable payment plans, and applicability to other healthcare providers beyond hospitals, because we are aware that while these resources, limited as they may be, are available to hospital patients, there's a lot lacking for patients who receive services outside of hospitals as well. And we also remind hospitals of the AGO's recommended medical debt reporting practices. Next slide.
So we also recommend efforts in engagement around lower cost coverage for lower income households. Our 2022 data shows that certain households may be caught in affordability gaps in particular. These include households getting insurance through the individual market, particularly households that may not be eligible for CSR subsidies. And so to address this gap, we recommend policymakers consider maintaining enhanced subsidies for connector participants. So for purchasers in the individual market, we observed in a report the success that the current Connector Care pilot program has had in expanding access to lower cost health insurance to an additional 50,000 Massachusetts residents. And so we recommend that policymakers consider maintaining this expansion. And our findings also show that lower income households who get their insurance from their employer and therefore are not eligible for CSR premium subsidies may also struggle with healthcare costs. So to address this gap, we recommend that employers, where possible, consider pay-based or tiered premium contributions and or other cost-sharing programs that lower costs for lower income employees. This in part, of course, echoes recommendations made by the HPC in the past. And as discussed in our report, this is something that is being done by some number of employers already. And we provide some citations in our report to give some examples of what that would look like. Next slide.
Finally, we recommend further support for lower cost and safety net hospitals. As discussed, these hospitals are disproportionately shouldering bad debt, and we are aware that a number of our recommendations do ask for the hospitals to do more for patients. And so we want to keep in mind that in conjunction with those recommendations, we think it's important to increase supports for these hospitals, and that could include strategies to reduce unwarranted provider price variation. And that concludes our presentation. We thank you again for your time and your attention, and we are happy to answer any questions.
Thank you so much. Questions or comments by commissioners? Dr. Cutler?
So I thought that was an excellent set of findings and presentation of it too. I guess I just had a couple of comments. One is, in addition to the means, we may also care about like some of the outliers, like really high values of things. And so it would be fascinating to see not just like what did the mean amounts look like, but what is the 75th percentile or the 90th percentile or someone with a very high level of spending look like. My sense is we do better than other states at capping that amount. That is, it doesn't go up like as much in Massachusetts as in other states, but I don't know about that. And then the second comment is, there's been actually some work on medical debt and all the reporting. So it's now mostly not reported to credit agencies, which is very good. Unfortunately, it doesn't seem like that has enormous impacts on people. I think in part because people with medical debt have so much other debt that just saying, okay, we're not going to report the medical debt or we're going to wipe away the medical debt doesn't increase people's financial resources that much. So I'm quite in favor of it, but I'm also, I think the literature is unfortunately that by itself won't have an enormous impact. And so we're going to have to go far beyond that in terms of thinking about that. And then I guess just the final thing, which is, as I looked at some of this, I thought to myself, for quite a number of people, low, middle, and even some high income people, they would far rather have less expensive, less prestigious perhaps, but less expensive choice of providers than say, something that people would otherwise consider more prestigious, but just more expensive. And so given the choice, people often choose sort of narrow networks with low cost sharing. And there's no reason why people are wrong to do that. So we should maybe think about that in terms of other kinds of recommendations. That is, in addition to having, a broad network choice and stuff, maybe we should, encourage employers to say, well, look, and we've also got a plan which it's not as generous in terms of where you can go, but like you're not going to have that out-of-pocket cost associated with it. So, so maybe that appeals to people.
Good, thank you. Dr. McGregor?
Sure. So first of all, thank you so much for a wonderful presentation. It was informative, eye-opening, and heartbreaking in many ways. So in particular, I was struck by the slide that showed that for those households in the lowest income quintiles, that for individuals who received insurance through the individual market, that their level of sort of share of out-of-pocket expenses seemed to be actually lower than those who were obtaining insurance that was through their employer. And that made me wonder, is there anything else we can find out with the data that you have about sort of what percentage of those who are insured through employer-sponsored insurance are employed in small businesses versus larger companies or organizations? And also, is there a way to break out the differences in cost sharing across sector of employment? Do we know anything about that?
I don't know that we collected that to that level of detail. I mean, certainly we could. I don't know that we did, or we kind of sliced it in that way.
Sure. Yeah, I think that could be really informative for what's happening, especially with the more sort of financially vulnerable households, because what you showed in terms of the regional differences was really striking in terms of what households are facing in Lawrence and in Lowell. So just curious to know what's going on at the various employers. But thank you very much.
Commissioner Haupt?
Yes, that report was really quite eye-opening. I just had a couple of questions about data, not so much sources, but when you got the data about the level of the deductible in the underlying plan, that was from the health plans themselves reporting. So
Yes.
Is there any type of mechanism in there to also ask for their clients if they're offering an HRA or an HSA in addition, which subsidizes the amount of that deductible? So
yeah, we did not ask for that. I mean, again, we have relatively broad power. We could in the future, but that was not something that we particularly collected this time.
Yeah, I think it's very difficult to collect, but increasingly employers of all sizes are moving toward a higher deductible and basically self-insuring part of that difference. So it distorts the data because the trend is always going to be toward increasing that deductible, but that $5,000 deductible might actually be a $2,500 deductible. Yep. At the end of the day. And often employees don't even realize that. And they're not taking advantage of it if it's not automatically built into the reimbursement. So it's problematic from a lot of different perspectives. The other is just a comment. I couldn't agree more on pay-based subsidies, I guess, for employers to consider. The one pushback or concern I've heard about that is you obviously know if an employee is single what they're making, but you don't know as an employer what the family income is. So you could have a low earning person that you're employing, maybe in a university setting or something like that, and the spouse or domestic partner might have a very high paying job. And I'm not saying it's right or wrong. I'm just saying it's an obstacle that people have run into.
Thank you.
Yep.
Good point. Commissioner Master Giovanni?
Thank you. Excellent presentation. Appreciate it. Just a comment based upon the employer. I just want to fill you in on what happens in my firm. Small company, and the company pays 75% of the premium. And the employee gets to choose any of the plans being offered by the insurance company. What's interesting is what we do is we take the highest cost plan and we take 75% of that. And now the employee can choose any one of the plans that are available. And in some cases, the employer ends up paying 100%. But guess what? Maybe we have one or two people that don't purchase the highest cost plan. And I don't know if that tells us something when we're looking at the cost of the plans. And I'm talking about young people in general. And so I just thought I'd bring that up just to let you know, it's a complicated topic and there's a lot of fear involved. And, I think that drives a lot of the decision.
Absolutely.
Commissioner Castillo?
I also want to echo that this was a great presentation. I want to know how realistic the last paragraph here, including strategies to reduce unwarranted provider price variation, and how we would actually go about doing that. I think that's the majority of things that I know here people talk about. And the other piece is I like the idea of knowing the debt, the municipality knowing the debt, and maybe as a community, how can we help with that debt? And I heard the last comment that is it really going to change a whole lot, but it's something that we can do. And if we could figure out a way to have that data, that would be great.
Good point. Other comments or questions? Well, thank you so much to both Assistant Attorney General Garland and Cable. As you can see from the discussion, a lot to think about, and we appreciate the recommendations that you've put forward. I also want to note that the AGO's full cost trends report is available on the HPC's cost trends hearing webpage for those who are interested in delving in further. Thank you. So we will now move to the next agenda items, which are the HPC's evaluation of Mass General Brigham's Performance Improvement Plan, and after that discussion to a vote on that, the success of that Performance Improvement Plan. I'll turn it over to our Executive Director, David Seltz, to introduce the topic.
Thank you, Chair DeVoe. Thank you, Commissioners. Just to put a little bit of a bow on the last presentation, I did want to let Commissioners know that we, HPC staff, have been still hard at work at contemplating what an affordability benchmark or an affordability index would look like. We've been meeting with our colleagues at CHIA around adjusting some of our data reporting requirements to be able to get the type of granular information that we'll need to be able to do just the types of things that the Attorney General's office just presented on, to be able to have both the employee and employer contribution, to be able to look at it by geography and zip code. So that is an active work stream that we're still working on, and I'm excited to be able to update you on that work next year. And as sobering as those findings were on affordability, one of our key mechanisms in this state for promoting affordability is through moderating total healthcare spending. And that is through compliance with the healthcare cost growth benchmark. And so now we're going to shift to a conversation about the performance improvement plan of Mass General Brigham. Just as by way of introduction, before I turn this over to Kara Vidal, I will note this was the first performance improvement plan mandated by the Health Policy Commission through the process established in Chapter 224 to provide accountability to the state's healthcare cost growth benchmark. This concept of a performance improvement plan designed and implemented by a health system or a health plan, approved and overseen by the HPC, with the goal of delivering meaningful healthcare savings within 18 months, was completely untested until now. And just as Massachusetts was the first state to establish a healthcare cost growth benchmark, to our knowledge, this is the first PIP of its kind implemented in the country. Just as other states have followed our lead in establishing their own healthcare cost growth benchmarks, there are other states who have also followed our lead in putting PIPs in their statutes as an accountability mechanisms for their benchmarks. And they have been watching this process closely. So once again, Massachusetts is paving the way. This has really been a multi-year journey to get to this discussion. In January 2022, the Health Policy Commission Board voted to require a PIP of Mass General Brigham, the state's largest healthcare system. That performance improvement plan was implemented between October 22 and March 2024. It ended earlier this year. We worked incredibly closely and collaboratively with Mass General Brigham during that entire time period. And I want to recognize that MGB conducted this work and implemented this plan that you're going to hear about during a time of significant challenges in our state's healthcare system. We closely monitored MGB's performance throughout this PIP, and in the last 6 to 8 months have been conducting our own analysis of their performance and evaluating the results of this performance improvement plan. So that is the presentation that we're going to be presenting the results of, presenting to you today. And with that, I'm pleased to turn it over to Kara Vidal to share our results.
Great. Thank you so much, David. Good afternoon, commissioners. Nice to be here with you today. So as David was saying, under Chapter 224, the HPC is charged with conducting an annual process of accountability to the healthcare cost growth benchmark. Each year, the HPC reviews the spending performance of payers and providers, referred to it by CHIA for having spending growth that is excessive and that threatens the Commonwealth's ability to meet the benchmark. We conduct a robust, confidential review of all referred entities, and we engage directly with payers and providers to understand the causes of their spending growth and to encourage them to drive towards greater efficiency. Based on that review, we can also require a performance improvement plan of an organization where the HPC identifies significant concerns and feels that a PIP could result in meaningful cost-saving reforms. And as David said, today I'm here to share with you the results of the Commonwealth's first ever PIP of Mass General Brigham. Just to let you know where I'm going to be going over the next couple of slides, I'll first very briefly describe the factors that led the HPC to require a PIP from Mass General Brigham. Next, I'll provide an overview of their PIP, and then I'll review the HPC's findings. Next slide, please. Thank you. So as I said, the HPC reviews entities who are referred based on high spending growth. That high spending growth is based on a measure called total medical expense, or TME. And in this case, TME represents total spending for Mass General Brigham's primary care patients. So this includes all spending at MGB facilities or at their providers for their primary care patients, as well as spending for services provided by unaffiliated providers, pharmaceutical spending, et cetera. To be clear, it's not reflective of total revenue at MGB facilities or providers. It's not related to MGB's internal costs or efficiency. So that's the basis for referral. That is the first factor that you see here listed on this slide that the HPC uses to determine whether or not a PIP is warranted. But we don't just look at that. We also look at data like pricing and utilization, population served, each of these factors individually. And in January of 2022, as David said, the Health Policy Commission reviewed detailed information on each of these factors. I'm going to give you a very high-level summary on the next slide. Thank you. So in its review of MGB's spending performance, the HPC found that from 2014 to 2019, MGB's above benchmark spending growth resulted in $293 million in excess spending, or spending that would not have occurred if its growth had stayed within the benchmark. That was more than any other provider. We also found that MGB had high spending levels and high prices, and that price and mix were key drivers of its growth. The other factors the HPC reviewed did not mitigate these concerns. Next slide, please. So based on these findings, the HPC voted to require a PIP in January 2022. The HPC determined that MGB spending growth raised significant concerns and that a PIP could result in meaningful cost-saving reforms. Next slide, please. Great, thank you. So now I'll turn to a review of some of the details of MGB's PIP. PIP proposals must conform to a set of standards in our regulations. That includes, for example, having a timetable of 18 months or less and addressing the causes of the entity's cost growth. The HPC reviewed MGB's PIP proposal in September of 2022 and found that it conformed to these requirements, that it was reasonably likely to successfully address the underlying causes of MGB's growth, and that MGB would be capable of implementing the PIP. And based on these findings, the board approved the proposal. Next slide, please. So what was in that proposal? MGB's approved PIP sets a total savings target of $176 million over the 18-month period. That amount was anchored to the $293 million in excess spending that I described just a few slides ago with some adjustments. So for example, recognizing that the implementation period is only 18 months long, whereas that 293 million figure had been accumulated over 6 years. The target was adjusted to account for that fact. It was also adjusted to account for the fact that the 293 million figure was based on TME, so again, spending for MGB's primary care patients. However, many of the strategies that MGB proposed had broader implications. So some adjustments there, but anchoring to that $293 million. The PIP included 10 strategies organized into the 3 categories that you see on the right: price reductions, reducing utilization, and shifting care to lower cost sites. MGB also, in its approved PIP, described efforts to control costs through its value-based care strategy, but it didn't quantify any savings associated with those efforts. One important point here is that the price reduction strategies collectively made up more than 70% of MGB's total savings target. And we thought this was particularly important given the requirement that the PIP address the causes of growth and that we had identified price as a driver of MGB's growth. Next slide, please. Here you can see a timeline of the PIP. So it ran for the maximum 18 months allowed in regulation from October 2022 through March 2024. You can also see here the start date of the different strategies. You can see some variation here. And you can also see that some of the strategies, as indicated with an asterisk, actually began prior to the PIP implementation period, though I will note that the savings calculations only include savings accrued during the 18 months of the PIP. Next slide, please. At the end of the PIP implementation period, MGB submitted a final public report on its performance. In that public report, MGB stated that it saved a total of $197.1 million, exceeding its target by more than $20 million, or 12%. MGB also described some of the factors that led to its results overall, including in areas where it exceeded the target, some factors leading to that exceeding of the target, and in other cases, explanations of challenges that it faced and why it might not have met the target. As you can see on the slide, most of the strategies met their savings target, and MGB reports savings that exceeded the target overall. Additional detail on each of these strategies is available in MGB's approved PIP, as well as in its final public report, as well as in our final evaluation report, all of which either are on our website or will be shortly. All right, so on the next slide, we will turn to the question of evaluation. The PIP regulation lists 5 factors that the HPC may consider when determining whether a PIP was successful. So that includes whether and to what extent MGB addressed significant concerns about its costs, whether MGB fully implemented in good faith the PIP, sustainability, the impact of factors outside of MGB's control, and other factors that the Commission determines to be relevant. On the next slide, you'll see that we organized our evaluation into 3 broad categories that address the factors listed on the previous slide. The first of these categories is achieving target outcomes. So in this section, we're really focused specifically on the activities of the PIP and the question of whether MGB implemented those strategies in good faith and whether it achieved the target savings. The second category is spending and pricing during the PIP. So here we're taking a step back from the PIP activities themselves, and we're assessing some key measures, specifically those measures that we had identified as areas of concern in the lead up to the PIP, to see whether and how they changed during the PIP implementation period. And then finally, we look at sustainability and consider whether the strategies and savings are likely to be sustained beyond the PIP. We incorporated a consideration of factors outside of MGB's control into each of these 3 areas. Next slide, please. All right. On this slide, we are summarizing our findings. I will give you the high-level summary here, and then we will go through each of these in detail. So in the category of achieving target outcomes, we found that MGB implemented the PIP in good faith and achieved the savings target set out in its PIP. In the category of spending and pricing during the PIP, we found that during the PIP period, MGB's spending growth was meaningfully reduced, and its pricing was likely modestly reduced relative to the market. And then finally, in the category of sustainability, we found that MGB has stated that it will continue several strategies after the PIP, and that MGB's rate increases in recent finalized agreements suggest that it is not recouping the savings generated under the price reduction strategies in current payer contracts. We also found that some of the factors that MGB cited as evidence of the sustainability of the PIP have not previously been shown to be sufficient to constrain its growth, and that ultimately the long-term sustainability of the PIP will depend on MGB maintaining a commitment to keep its pricing at levels consistent with compliance with the benchmark. Okay, I will now provide some additional detail here, though much of the data and information that we reviewed is confidential and cannot be shared, and was therefore reviewed by commissioners in executive session prior to this public meeting. Next slide, please. Okay, our first finding A1, is that MGB implemented the strategies in its PIP in good faith, even in the face of ongoing challenges in the healthcare system during this time period, such as inflation, capacity constraints, wage pressures, and more. They implemented the strategies as they said they would. They were in very regular communication with us. The graphic here shows the formal checkpoints where we were in touch, but I will say that we spoke with their staff much more frequently than this. In these communications, MGB proactively identified implementation challenges, and they worked to address them where they could. And they also made a commitment early in the PIP that they would achieve their total savings target, even if some individual strategies fell short. Next slide, please. Okay. Our second finding is that MGB achieved the savings target in its approved PIP. We reviewed MGB's methodologies in great detail. We had many technical questions that we addressed with their staff, and we generally found that their methodologies were reasonable. We also found that savings associated with commercial pricing strategies had the most impact. Though we note that there were certain ancillary spending impacts that could not be accounted for, and that a portion of the reported PIP savings was returned to MGB as shared savings payments under its value-based care arrangements, overall, the scope of savings achieved was consistent with expectations. Next slide, please. Okay, we are now zooming out to look at spending and pricing trends during the PIP. So finding B1 is that during the PIP, MGB spending growth was meaningfully reduced. Here, we examined MGB spending trends as measured by TME with 4 local commercial payers. We're looking specifically here at growth from 2022 to 2023 because 2023 was the only full calendar year when the PIP was in effect. I also want to note that this analysis was done with preliminary TME data from CHIA and is therefore subject to change. To assess MGB spending trends, we looked at it a few different ways. So, for example, we compared MGB's growth to the benchmark. We also compared it to average performance in the market during this time and to MGB's historic performance. Based on this preliminary data, we found that spending growth for Partners Community Physicians Organization, which is the largest physician group in the MGB system, generally exceeded the benchmark. As we mentioned before, this was likely affected by some of the pressures on the healthcare system overall during this time period and may not reflect MGB specific actions. However, when we compared MGB's growth to each payer's network average growth, which is what you see in the table on this slide, we found that MGB spending was consistently growing more slowly than the payer's network average on both a health status adjusted basis and an unadjusted basis. This was a significant change from the pre-PIP period, when MGB's spending growth was at or above network average with 3 of the 4 payers that we assessed. We also wanted to assess whether the magnitude of savings was significant relative to MGB spending trends. So to do that, we added the PIP savings back into MGB's 2023 trends to assess how their trends would have changed. And we found that if the magnitude of the PIP savings were added back to MGB spending levels, MGB would have exceeded the network average growth in 2023. Next slide, please. We also wanted to look at MGB's outpatient spending trends specifically, which should have been impacted by some of its larger strategies, including its reducing outpatient rates strategy and its Mass General Waltham strategy. So here we're comparing again MGB's outpatient growth relative to each payer's network average growth in both the pre-PIP period, which is what you see on the left, that 2013 to 2022 annualized, and the PIP period of 2022 to 2023. And as you can see, before the PIP, MGB's outpatient spending growth was consistently above network average. From 2022 to 2023, it was below. Okay, now turning to our measure of pricing during the PIP. Thank you. We found that during the PIP, MGB's pricing was likely modestly reduced relative to the market. So MGB stated in its PIP that one of its goals was to decrease price variation between itself and the marketplace. So to test whether it met this goal, the HPC used 2022 relative price data from CHIA to estimate a single system-level inpatient price for MGB and a single system-level outpatient price for MGB. And looking in that baseline period in 2022, we found that MGB's system pricing was between 9 and 35% above average on an inpatient basis, and between 14% below and 35% above average on an outpatient basis. Then we applied price increase data to recalculate those figures in 2024. And we found that in 2024, MGB's system pricing was between 5% and 28% above average on an inpatient basis, and between 17% below and 30% above average on an outpatient basis. So modest changes from the first bullets, but in the right direction. And so we therefore find that MGB's contracted rate changes during the PIP likely slightly reduced its prices relative to the average with the local commercial payers, consistent with MGB's stated goal of decreasing price variation. Okay, the final set of slides here are related to sustainability. So first we assessed whether the PIP strategies themselves were likely to continue, and we found that MGB has stated that it will continue implementing several strategies after the PIP. Some of these statements were made in the context of the PIP itself, such as MGB's stated commitment that it will keep the Mass General Waltham facility, at the community hospital rate schedule rather than the AMC rate schedule into the future. Other statements were made publicly, such as MGB's recent statements about the expansion of its home hospital program and certain capacity milestones that it has hit there. Next slide, please. We also looked specifically at MGB rate increases in our evaluation of sustainability, given how much of the total savings was generated by MGB's pricing activities, and given that we identified price as a driver of MGB's growth. In particular, we were assessing whether MGB complied with its commitment in the approved PIP that it wouldn't recoup savings generated under the PIP via future rate increases. The HPC examined MGB's 2024 and 2025 aggregate price increases with local commercial payers compared to the healthcare cost growth benchmark, MGB's historical increases, and the payers network average increase for each year when available. We found that it is unlikely that MGB recouped the revenue it forewent during the PIP through higher rate increases than it would have sought otherwise. Next slide, please. And finally, we assessed MGB's own statements about the sustainability of its PIP in its final public report. MGB cited factors like the use of multi-year payer contracts, as well as its review of CHIA benchmarking data and its participation in value-based care arrangements. We note that most of the factors MGB cites were in place prior to the requirement to file a PIP and were insufficient constraints to prevent MGB's high spending growth across multiple payers and years. And we find that ultimately, given the role of pricing in driving MGB's growth, sustainability of the PIP savings will depend on MGB's own actions, including maintaining a commitment to pricing at levels consistent with compliance with the benchmark, including in value-based care arrangements. On the final slide, you'll see those same conclusions listed there again. That concludes my summary, and I'm happy to answer any questions.
Thank you, Kara. Commissioner Cohen?
Kara, excellent job, and just kudos to you and your staff for the work that's gone into this. I know it's been a long 18 months and then the period of evaluation. I'm just, and I think the results speak for themselves. I think a lot of us had doubts of whether this would achieve the savings, and obviously it has. I think sustainability is the question on all of our minds. And I just, do we have I know we have the regular PIP process that will continue, but do we have the sort of metrics to be able to look at this over time to see that sustainability is in fact continuing?
It's a great question, Commissioner. I mean, I do think the PIPs process is our best avenue to continue monitoring. Not only does that include a review of that total medical expense data, but it is also the process through which we can engage directly with referred payers and providers. And so if an entity were to be referred again, if MGB were to be referred again, we would be able to use that PIPs process not just to evaluate its spending trends, but to seek additional information about its performance on each of those factors that we showed on one of the earlier slides. So pricing, utilization, payer served, patient served, payer mix, financial condition. And so in addition to the publicly available data from CHIA, we would have an opportunity through that PIPs process to request additional information.
I would also add the cost trends hearings provides another opportunity, a public opportunity to engage with the leadership at MGB and ask them in future years, how are they sustaining these savings?
Commissioner Cutler?
So thank you. Let me echo Marty's comment, which is to thank you for all the work and the presentation. I suppose for me, there's a headline and then there's a subheadline. So the headline is the PIP process worked. That is, it gave the citizens of Massachusetts what they wanted, which is some certainty about the nature of medical spending, and that's great. And like, there was a lot of issues at the start about, would it be successful and so on. And I think thanks to our efforts and certainly MGB's efforts, I think what we've learned is that it can be done. It can be done well, and it can have lasting impact. So like this is real savings for the people of Massachusetts, and they should feel very good about that. And we should feel good about that because not everything we do has all the impacts we would want. I think the subheading is what we know is that, by itself, this is not the only tool that we'll need in the toolbox. This happens afterwards, not in advance. It's sort of it's trying to patch things up. And so I think we need to continue all of our other efforts here, because this, while very welcome, is not, like if you thought of this strategy as being the HPC strategy, this by itself is not going to be it. But that much said, I feel like very good that overall this turned out to deliver what we wanted, and it will continue to bring savings to people over time, assuming that that things play out as folks have said they will and as we'd like to see them. So I'm overall feeling very good about it.
Thank you. Other comments or questions by commissioners about the analysis, the evaluation, the work with MGB?
Yes. If I may, the one thing I'd add, in addition to also feeling encouraged by the process and the outcome, is that in the future, it would be sort of necessary to see an evaluation of sort of how the savings were achieved, and really to ensure that the savings weren't made at the expense of some of our most vulnerable patients. So for example, MGB did sort of center some of its utilization reduction efforts around the members of the Mass General Brigham Health Plan. And I think it's important to know the extent to which these members are disproportionately Mass Health enrollees or otherwise sort of economically vulnerable. And so I think when it comes to evaluating these efforts, we ought to know the impact on the population as well. But otherwise, a generally positive outcome here.
Any other comments or questions? Or Cara, any other thoughts on your part that you wanted to add?
No, thank you.
I do want to underscore the point that was made earlier, that I think that we can take away from this that engaging in a performance improvement plan with an organization that is prepared to provide the rigor and the commitment to that plan has proven to work. And I also want to acknowledge for the HPC team that this was the first time implementing a PIP, so there was a great deal of helpful learning that occurred about how to receive data, how to probe that data, and it certainly was, it required a lot of back and forth, and we appreciate the leadership of Dr. Klebansky and Dr. Greg Meyer in that exchange. Other comments or thoughts from HPC team or commissioners? Commissioner Foley?
Yeah, thank you. I don't want to be too repetitive of what's been stated before, because I agree with a lot of the comments that have been made. But I do think it's, again, just important to reinforce the milestone for the HPC staff and team for all the work being put into this process. Again, acknowledging that this is the first time this has been done. To your point, Chair, we've got a lot to learn and apply in the future, and that our role continues, right, to monitor the impact of costs and quality, and the game's not over. It's just the another experience that we've been through that's going to really strengthen our role going forward. And I think reinforces our policy recommendations that we made at the cost trends hearing and have made at the end of each of those cost trends hearings or annual report, that we have certain tools that allow us to take on certain things. And this showed that one of those tools can be successful, but that it's not going to solve all the issues and problems we're having with costs in the market, and that we have to have additional tools to continue the great work that we do. I think it's a perfect example of the law being implemented in a way that was intended to, with the outcomes it was intended to. And to think if we were given additional tools and the expertise and the experience can be applied to those additional tools, only good things can happen in our healthcare market. So I just think it's really important that we also just continue to reflect on the policy recommendations and the great work that's been happening in the legislature to move those policy recommendations. Or almost there again, but that work can have an impact. And I think given what we've seen here today, it just reinforces the important role that HPC can play. And I want to congratulate everyone involved in a successful effort.
Thank you, Commissioner Foley. Just to build off of that point, I wanted to point out one thing that I found really interesting is that many of the strategies that were successfully implemented by MGB, are really consistent with the HPC policy recommendations that we have for the entire system, such as addressing high commercial price growth, rationalizing hospital outpatient payment rates, shifting care to lower cost settings like hospital to home. So they were able to do this. And so I think we look forward to working with legislators and policymakers and industry leaders to see how we can catalyze greater adoption of these successful strategies across the state. So thank you for that comment.
Other discussion or questions before we move to a vote? Seeing none, we'll move to consider whether the PIP was successful by a vote of the board. And as you can see on the slides, these are the options that we have in terms of voting.
Okay. I am going to call for a motion to vote to determine if the Mass General Brigham PIP was successful. Is there a motion?
I would move that the performance improvement plan implemented by Mass General Brigham was successful.
And a second, please.
I'll second it.
Thank you. Okay, by a roll call vote of each commissioner present, Chair DeVoe.
Aye.
Vice Chair Cohen.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Castile.
Aye.
Commissioner Cutler.
Aye.
Commissioner Haupt.
Aye.
Commissioner Master Giovanni.
Aye.
Commissioner McGregor.
Aye.
Commissioner Sullivan. And Secretary Walsh.
Aye.
Thank you.
Colleen, Commissioner Foley too, aye.
And Commissioner Fuller.
Sorry, I know I joined a little late.
Thank you so much. Thank you.
Thank you. And I want to reiterate the board's thanks to the team, a tremendous amount of work on the part of our team that I think has served us all very well and has created a good roadmap for us going forward. So thank you. We are going to hold on the next agenda item, the research presentation on behavioral health emergency department boarding. Extremely important topic, and we don't want to shortchange it. So in the interest of time, we're going to put this on a future public agenda, and we will move to our executive director's report.
Thank you, Chair DeVoe. And just to say just a quick word about the research work on behavioral health emergency department boarding. I'm excited to be able to share this work with you and have it in a future meeting. I put it on today's agenda And we will have it on a future agenda because, you know, this really was one of the topics that came up at the cost trends hearing, where we really heard about some of the challenges that our system is facing around really being able to treat patients kind of in the right setting, in the right place, and seeing the increased rates of specifically mental health patients being stuck in the emergency department, the strain that has on the clinical staff, but also you know, just the harm that has for patients, and so really wanting to think about not just the problem and the challenge that is, but to really engage in a conversation about how we can really move towards some actionable solutions. I think that's going to be a major theme that you're going to hear from me in 2025, especially coming out of the cost trends hearing. So I really look forward to working with you board members on taking some of those big problems that we heard at the cost trends hearing and picking and prioritizing the ones that we really think we can help make a difference on. And not a difference in 2 to 3 years, but a difference in this year, in the next 12 months. And so I look forward to those conversations. We're going to close this last meeting of the year with a couple of quick hits in this executive director's report. First, we're going to start with our classic update on material change notices. For that, I'll turn it over to Kate Mills.
Thank you so much, David. So you all know this slide well, summarizing the material change notices we've received to date. So in total, since 2013, we've now received notice of 184 market changes. And of these, transactions involving changes for physician groups are now the most frequent. And on the next slide, you'll see that, as you know, staff are continuing the cost and market impact review of the proposed affiliation between Dana-Farber, Beth Israel Deaconess Medical Center, and the Harvard Medical Faculty Physicians. And the next slide shows the timeline for that review. As shown here, the parties have now substantially complied with the HPC's information requests. So staff are now working to complete our analyses and looking to release our review in the coming months. On the next slide, you see the update since our last board meeting. So since our last board meeting, we've completed review of 5 notices of material change. So first, following our last meeting in which we discussed the review in depth, the HPC did close review of the acquisition of the Steward Healthcare System subsidiary Stewardship Health, its subsidiaries Stewardship Health Medical Group, which employs primary care and other clinicians across 9 states, as well as Steward Healthcare Network, which is their provider contracting network by Rural Healthcare Group, a subsidiary of the private equity company Kinderhook Industries. That has now been renamed Revere Medical. And I'm not going to restate all of our findings here, given that we went through them in great detail at our last meeting, but I will note that, as discussed, HPC plans to closely monitor Revere Medical's operations in Massachusetts going forward. Second, we completed our review of the creation of Northeast Orthopedic Alliance, or NOA, and an affiliated management services organization from 4 existing orthopedic group practices in Massachusetts and New Hampshire: Boston Sports and Shoulder Center, E1 Medical Subsidiary, and New England Orthopedic Surgeons. And in our preliminary examination, we found that the transaction has some very limited potential to increase spending if the new entity were able to raise the commercial rates of some of the lower priced groups that are joining to equal those of some of the other groups. That said, this is going to be an independent group, so it's not anticipated to have greater bargaining leverage than the parties' current contracting affiliates, the ILH, Baycare, and Lawrence. And so we did not review evidence suggesting also that the transaction would have any negative impacts for quality or access. Third, we reviewed a contracting affiliation between Mass General Brigham and Healthcare South, which is a for-profit family practice, internal medicine, and pediatric primary care group practice with 9 locations on the South Shore. Healthcare South has been a contracting affiliate of Tufts Medicine Integrated Network. And under the proposed transaction, Healthcare South proposed to switch its contracting affiliation from Tufts to MGB. In that preliminary examination, we did find that the transaction is likely to result in a small increase in annual spending due to changes in commercial rates as Healthcare South transitions to contracting through MGB, which has higher prices generally than the Tufts network. This would be partially offset, however, by some savings as Healthcare South's pediatric patient population would be shifting referrals from Boston Children's to the lower priced Mass General Hospital. And we did not review any evidence suggesting a negative impact on quality or access. On the next slide, you'll see that we also completed the review of the acquisition of Alden Court Nursing and Rehabilitation Center, which is a 142-bed licensed nursing facility in Fairhaven, owned by the for-profit Gordon Operating Company by South Coast Health System. And in our preliminary examination, we found limited potential for spending increases due to the transaction. As detailed in the CHIA cost reports, Alden Court's revenue comes very predominantly from public payers, limiting the impact of any potential changes on commercial prices. And the HPC did not review any evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. And then finally, we completed the review of the acquisition of Rotech Inc. by Owens & Minor Inc. Both of those parties are national manufacturers and distributors of durable medical equipment. And in our preliminary examination, we found limited potential for increased spending in Massachusetts here as well. The commercial durable medical equipment market is relatively fragmented, and commercial price variation appears to be relatively limited, making it less likely that the parties would be able to raise commercial prices as a result of the transaction. Again, we did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. And then finally, on the next slide, you see that we are currently reviewing 3 other MCNs in addition to continued review of cost and market impact review. First, the proposed acquisition of Vibra Hospital of Western Massachusetts, which includes an inpatient long-term acute care hospital and a skilled nursing facility by Everest Hospital LLC, which is a newly formed Massachusetts corporation in coordination with Neil Equities, which is a private investment vehicle with ownership interests in other nursing facilities. Second, the proposed acquisition of Springfield Anesthesia Service, which is a privately owned physician practice located in Western Massachusetts, specializing in anesthesia delivery by Bay State Medical Practices, which is a subsidiary of Bay State Health, employing over 1,000 physicians and advanced practice providers in Western Mass. And then finally, the proposed acquisition of Commonwealth Pathology Partners, a private practice pathology group employing 16 clinical and laboratory pathologists and additional pathology staff by Mass General Brigham. And I will pause there for any questions before I turn it back to David.
Seeing none, thank you, Kate. Thank you to you and your team. It has been a busy year of market oversight. Appreciate all that you do. For our next quick update, wanted to provide an update on a policy issue that the HPC weighed in on a few years ago, and that there has recently been some legislative action on. So for this update, I'm going to turn it over to Kate McCann.
Thank you, David. Thank you, commissioners. Thanks for hanging with us in this marathon end of year meeting. So as Director Seld said, just a few slides from me, but we're here to share an exciting update regarding the healthcare workforce in Massachusetts. So as David previewed, the headline is that pursuant to recent legislation signed by Governor Healy, the Commonwealth is joining an interstate compact called the Nurse Licensure Compact. And as alluded to, we've advocated for this for several years, and we're pleased to share this update today, which is a material development for the nursing workforce in the state. This slide includes some summary information about the compact, which I'll skip in the interest of time, but at its core, I will just simplify to say that a qualified RN or LPN who's eligible for and issued a multi-state compact license may then practice in any participating compact state in person or via telehealth without additional state-specific licensure. So that's really the principle of the compact at its core. And as you'll see in enacting the compact, Massachusetts is joining the vast majority of states in the country and nearly all states in the eastern United States. So on the next slide, before returning to the news, just a very brief reminder about where our concentrated interest in this topic began. The FY21 state budget required the HPC, in consultation with the Board of Registration in Nursing, to conduct an analysis and issue a report evaluating Massachusetts' entry into the compact. We engaged in a multifaceted effort that included consultation with Bourne and other experts, review of available literature, analysis of nurse and labor market data, exploration of key stakeholder perspectives, and engagements with other states, including NCSBN, which is the National Council for State Boards of Nursing. So we issued that legislative report in May 2021. It's linked here, and this is a non-exhaustive list of some of the key findings. A few of them are highlighted here. But I'll summarize to say that overall, there was no evidence that joining the compact would have a negative effect on quality of nursing care in the Commonwealth, and the ability to fill short-term staffing needs and facilitate telehealth in particular could yield positive effects for healthcare access, quality, and cost. All said, given the key findings in the report, the HPC recommended that the legislature enact legislation to join the compact, and we subsequently reiterated that recommendation in an annual cost trends report, as well as our special healthcare workforce event and associated chart pack that happened in 2023. So on the next slide, we will return to where we started, and I'll note that since our report in 2021, there really has been a considerable continued increase in membership in the compact. So in New England, at the time of our report, New Hampshire and Maine were the only compact states. And then later that year, Vermont joined the compact. In 2023, Rhode Island joined. And just earlier this year, Connecticut joined. So, and those are among other states that have joined around the country. So that left Massachusetts as the only non-compact state in New England. But we will now have 100% compact participation in New England. On November 20th, Governor Healy signed the Economic Development Bill into law, and that included the model legislation that's required to enact the compact in Massachusetts. So we become the 41st state and 43rd overall jurisdiction to join the compact. And anticipated next steps really center around guidance from the Board of Registration in Nursing that we anticipate Bourne, as a note, will administer the compact for the Commonwealth. And so anticipated guidance would potentially focus on implementation timeline, as well as other necessary process updates to implement it in this state. And certainly happy to take questions if we have time, but in closing, this is a significant development that could yield numerous benefits for the Commonwealth, including for healthcare employers, individual nurses, and Bourne. And we will certainly follow along as our partners at Bourne turn towards implementing the compact and watch with interest how it begins to bolster the Massachusetts healthcare workforce and address the dynamic needs of the system here. Yes, Commissioner Foley.
Thank you. And I know we're running out of time, so I'll be quick.
Yeah.
Just to that point of the potential positive or negative impacts of this, is there any way in which the HPC or anyone else is going to be evaluating the impacts of this change, either in the positive light that's been outlined or in the negative light that's also been outlined? How are we going to assess the effectiveness of this change on all the things you just mentioned?
Yeah, I think it's a great question, and won't speak for the board. I think we would defer to the board on that. But as far as I know, the enabling legislation didn't include any specific language around that. I think our neighbors to the south in Connecticut, theirs did, for example. So maybe something potentially in the future, but would certainly look to Bourne to squarely answer that in the meantime.
Thank you so much.
Yeah, good point. We'll take that away and consider it. Other questions or comments?
Just if I may, on Commissioner Foley's comment, one place to look for possible evaluation is that the compact has been in place for a number of years. And so there are many states out there that have multiple year experience with the compact that if we're looking for information sooner rather than later, There are hints and suggestions that that's there. I would also look at the National Council, because I'm pretty sure the National Council has been tracking the impact of the compact over years as well. So there are places to get information that we're not able to provide yet because we're just entering into a compact. Hope that helps.
Very helpful.
Okay.
Great. Thank you. So we are rapidly approaching the end of our meeting, so I am not going to present on these slides. This next section was really just a recap of the cost trends hearing. You can see here we included some key quotes from the different witness panels. On the last slide of this section, I had highlighted some of the kind of future priority areas that I had heard at the cost trends hearing around where we might want to prioritize our time and really diving deeper and having bringing people together and convening people around, as I said before, really being proactive on solutions. And so there's 10 items here. There are 10 huge items. So I'll ask commissioners to think about this deeply over the holidays and come back ready to discuss them with us in the new year, because this will help guide our work in 2025. Next slide.
Just gave us some homework, David.
Yes, exactly. Very importantly, Hannah, do you want to just share this quick slide and by the numbers?
Yes, excellent. Thank you so much. I am here back again at our December board meeting, my annual board meeting appearance to be an HPC cheerleader. So very excited, and we'll keep this brief. But this summer we welcomed our 10th cohort of fellows to our summer fellowship program. We had 7 fellows from 5 of the top graduate programs in public health, research, law. It's a 10-week paid fellowship opportunity, and we're very excited that today we'll be releasing our summer fellowship program report from 2024, which features the reflections from our 7 fellows. And then also wanted to do a quick plug for our upcoming 2025 summer fellowship program. We will begin accepting applications for that next week. I have the link for our careers page, our new webpage, masshpc.gov. Here, and that open opportunity will be available beginning on December 20th. So very excited to work with a new class of summer fellows, and that we're hopeful that you will share that with any graduate students you may know, looking specifically at our professors in the room. Okay, great. I will turn quickly to the next slide. Our annual by the numbers, our recap, the most HPC way that we can celebrate our milestone achievements over the year. I'll keep these brief, and there's a ton of numbers on here, of course, so I'll just pick a couple of them. On public engagement and outputs, the one I wanted to highlight was coming off of the last slide. We launched our new website in July, masshpc.gov, and since its launch, we have seen 14,000 unique users of that new website. So I think people have found us, and I think they're able to track all of our content. Which is very exciting, and I think everyone has experienced that it is a great user experience. So if you haven't checked it out yet, do so now. Meetings and conferences. I don't think anyone on this call will be surprised to hear that we convened 17 public meetings and presented over 800 slides during those meetings, many of which were today. So next year, I don't know that we necessarily want to try to top that number, but we'll definitely keep pace for that. Under our cost trends hearing, we had over 3,000 unique viewers of the cost trends hearing live stream. I think that is a record. So a great hearing, and David summarized his summary very quickly and very well, but very exciting to be able to amplify all of the events of that hearing with over 3,000 live stream viewers, in addition to the people who were with us in the room. On the next slide, our last categories. Market oversight. I don't think it'll be surprising that we received 21 new material change notices this year. Kate's been running through a ton of those at each of our board meetings. A lot of work completed by the Market Oversight and Transparency team. On our partnerships category, I want to highlight that one of the accomplishments of our Beside program, our investment program, was at the end of that implementation period, we tallied 132 total birthing people who received doula services at our 2 sites through the Beside investment program. And 117 babies were born, Beside babies were born through that program. So those are some of the numbers that we are always excited to receive and report out on. And then last but not least, the HPC's Office of Patient Protection safeguarded the rights of healthcare consumers this year and fielded nearly 1,500 phone calls to the OPP hotline. Our OPP team is small but mighty, and we're so proud of them. It's nonstop work, and they are the best people to do that job. So a year full of milestone achievements. Thank you all so much for all of your engagement and support of all of the HPC's work. And I will see you with the 2025 update next December.
Back to you, Madam Chair.
Thank you. Thanks so much. And look forward to thinking about those 10 areas of focus. I need to close our meeting by acknowledging that this meeting will be Commissioner Blakely's final HPC board meeting, as her current appointment term has come to an end. And I want to share with the public that Commissioner Blakeney has served on the HPC Board of Commissioners since February of 2019. She is our member with experience as a nurse who has demonstrated expertise in the development and utilization of innovative medical technologies and treatments for patient care. Commissioner Blakeney has served as chair of the Care Delivery Transformation Committee, and her thoughtful and practical leadership and commitment to high quality, affordable health care has been of tremendous value to the HPC and the Commonwealth. And I personally have benefited greatly from working with Barbara. I'm going to miss her. And I speak on behalf of my fellow commissioners in saying that we can see both in our executive sessions and in the public sessions your passionate and fierce commitment to our mission and to the broader Commonwealth. Thank you.
Thank you. Thank you so much for those kind words, Deb. I will miss the opportunity to join in our conversations. I will miss the camaraderie. I just want to acknowledge that my role is for innovation and for nursing, and I am so proud of the programs that we've put together, the Heartbeat pre-program that is just getting started, the Beside program that was mentioned earlier by Hannah, the C for Send program, and I'm especially proud of the effort that the Health Policy Commission has put in for the DEI work that has been undertaken in the last couple of years. I have seldom seen, as a matter of fact, I don't think I've ever seen an organization that has brought DEI down so deeply into the planning and the thought conversations and the implementation and programmatic efforts. It is universally within the system. It is embedded so deeply in the system that it is quite remarkable. I just want to say a couple of additional things, and I want to focus on our experience with Stewart Healthcare, because it has impacted us so greatly. I have little hope that there'll be a national solution that will protect our country from the kind of proprietary behavior that Stewart presented, and thus it goes to the states to protect its own residents. Last year, we had a speaker who described troubling quality statistics in private equity-involved hospitals, and there was one metric that stuck with me. And that metric was how significantly higher the mortality rates were in private equity involved hospitals. Right now, our legislature has a strong bill to help address preventing another Stewart that currently sits in the conference committee. And so I want to take this couple of minutes that I have to urge the legislature to complete its work and to pass a strong, comprehensive bill that provides the state and specifically the Health Policy Commission with the tools and the resources and the authority to substantially address this issue. Our motto must be never, ever, ever again does this state face a Stewart outcome. I have no doubt that the Health Policy Commission, under the leadership of David Seltz and Deb DeVoe, is up to the task of completing the work, whatever the legislature sees fit to provide. And I look forward to checking in and watching on YouTube and occasionally writing to one of you or engaging one of you in a conversation. It's been a pleasure and it's been an honor to serve at the House Policy Commission. And I wish you all the very, very best of luck going forward. Thank you for the opportunity.
And we look forward to that future communication also, Commissioner Blakeney. Thank you so much.
Thank you all very much.
And
You
with
will be
that,
missed, Barbara.
Thank you. Thank you, Marty. I appreciate that.
absolutely. And with that, I will now move to adjourn our meeting and wish you all a very happy holiday season and look forward to seeing you in 2025. Thank you.
Thank you.
Thanks all. Have a good day.
Bye-bye, everyone.